So, hi everyone. Welcome to the second class of MS lecture series. We have today Dr. Penny Smyth, who will be talking about clinical aspects of MS. Dr. Penny Smyth is an associate professor at the University of Alberta and a multiple sclerosis clinician at the Northern Alberta MS Clinic. Dr. Smyth works in education and administration as the Associate Dean of Professionalism for Medicine and Dentistry since 2017, while participating in MS clinical research and quality improvement projects. She's an active member of National NMS Training Research Network and Alberta MS Network. She also works closely with the MS Society. Dr. Smyth collaborates in local and multi-center clinical trials, helping in knowledge translation, and is a site lead for CanPro study. She was a contributor to National Treatment Guidelines for MS in 2013 and 2019. Dr. Smyth teaches about MS in multiple settings to learners from different backgrounds and levels, in addition to people living with MS. So thank you, Penny, for agreeing to talk today. And yeah, over to you now.
Okay, thanks so much, Neetu. Welcome, everybody. I hope that the audio and everything is going to work okay. I always get a little bit leery at the technology, but it's all good. We're all learning. I was really excited when we asked me to speak about clinical aspects of multiple sclerosis today. It's really one of my favorite topics, as we know, and I could go on about this for hours. So it was a good time for me to kind of revamp the talk, make sure that parts of it were up to date, and try and gear it more towards a multidisciplinary research trainees. The first picture that I have here is taken from this review about multiple sclerosis, which was done by Daniel Reich and in the New England Journal of Medicine in 2018. And I thought it was just a really nice cartoon about sort of MS pathophysiology, as well as connecting it to the different therapies that we have. And I would encourage research trainees, if you have a little bit of time and you want to just have some general reading about MS, that this is a very nice compact review that encompasses a lot of relevant topics. So my goal for us this morning is that by the end of this session that students will be able to describe clinical presentations and symptoms of MS. I'm going to go over a little bit about how MS is diagnosed and a little bit of the red flags that gear us as clinicians down to MS versus something else. We're going to touch briefly upon the clinical course of MS, and then try and relate that back to therapies and where we have gone with therapies, which has been a super explosion in the 21st century. And then finish it off with some just a descriptor of approaches to treating MS, and I've put them into various categories to try and organize us. Of course, we can't cover all of this in detail in terms of therapies, because that would be a whole other session, but this will give you a little bit of an idea to our approach. So in terms of my disclosures, these are some of my disclosures here. I do some consulting work. And I saw that we had shared this slide with you last week, and I thought, well, maybe I should take it out, but then I decided to keep it in because I think this is really the basis of partly why we are so world-renowned in terms of our MS research. And as you know, Calgary is a big part of that, as well as Edmonton and Lethbridge, around why are we interested in MS? Because Canada has one of the highest rates of MS in the world, and Alberta is thought to have the highest rate in Canada. So it's a very significant issue for our Albertan population, and we have the opportunity here to study it and provide some groundbreaking research results which can help guide the world. Now, MS is the most common non-traumatic neurologic disability in people of working age. And this is a very old graph that I really feel still holds true, that most MS patients will have their onset between the ages of 20 and 40. Over time, more and more, we have seen that we've been able to diagnose MS better in those under the age of 20, and about 6% of those can be children, and up to 10% of people can recall their first symptoms occurring before the age of 18. And more, we are also identifying it in people over the age of 50, although we are always careful at that point. We always do a little bit of careful exclusion of other things. So let's just take a moment and think about who are these people who are between the ages of 20 and 40 or 50. And I usually say at this point, these are people like you and me. Pretty soon I'll have to bring myself out of that category as I move on past 50. But what are we doing during those periods of time? So we are going to school. We are completing degrees. We are establishing careers and working in jobs and trying to contribute to society as well as save up for retirement one day. We are looking at building relationships, perhaps considering having families and children. And so this is really us in the prime of our lives. We have personal goals during these times. We have goals to want to complete a triathlon or maybe a marathon or something. And so this hits you, this MS, right at that crucial time period, which, as you can imagine, can be really traumatic for people that are diagnosed. It can completely destroy their thoughts of themselves, and then they have to rebuild that over time. And I'm spending a bit of time on that because that's a lot of what we do as clinicians, which is not really captured in review articles around approaches to MS and stuff. There's this huge kind of psychological overcoming of this diagnosis, which is going to really be with them for the rest of their lives. And these people live a really long time after they've been diagnosed with MS. Their lifespan is about 6 years less on average from the general population, but they live a good long time, and they're diagnosed in their 20s and 40s. So we are inheriting these people as new MS diagnoses, and we're really caring for them throughout the rest of their lives and trying to go through their obstacles and challenges in life with them and try and keep them as well as possible so that they can live that long life and die of other things at the end. Now, I'm not going to go into this in a lot of detail, except to say that, acknowledge the fact that this MS is an overactive immune problem that has this breakdown of myelin, inadequate repair, and degeneration, and involves various parts of the immune system. The reason why this is important is this actually is what comprises the basis of how we approach our people with MS on terms of our therapies, in terms of keeping them well, and in terms of lifestyle strategies that we try to target to try and change the course of disease over time. So you can see a nice, really nice link there between the environmental risk factors that we have for MS, the overactive immune system, and then maybe partly around the infections, maybe a little bit of a genetic profile. So this really encompasses all that you do as researchers and how it directly impacts me as a clinician in terms of how I approach my patients. So let's go into a little bit about some of the clinical presentations and the symptoms that can occur with MS. MS is so fascinating because while we have had this kind of explosion in research and understanding in the 21st century, we really do stick to the philosophy that was outlined by Charcot in the 1800s around what we think MS is, and that really forms the basis of how we diagnose MS. We are look at a chronic inflammation that culminates in events throughout the central nervous system, the brain, the spinal cord, and the eyes, at different places throughout that central nervous system and at different times throughout a person's life. So this descriptor by Charcot is actually still what we use and apply on a daily basis when we're making a diagnosis about MS, and then also how we're monitoring MS over time. So how I explain that to my patients, when I talk about this idea of multiple meaning many, that you have to have multiple events, sclerosis meaning scars, inflammation that results in a scar. And we see those as the white spots that show up on the MRI. We know that there's a broken wire where there's a breakdown of the nerves, and that's with the demyelination, the taking away of the myelin, that people undergo a spontaneous recovery to fixing that wire. That's why they recover from their clinical events. But that wire and that repair is not perfect. Kind of like that duct tape that goes around the wire. It works well in certain situations, but if the situation or environment is dicey, that duct tape might not hold on and work really well. And so a lot of our MS patients will manifest clinical signs when they are tired or when they are exposed to heat, because that repair area doesn't work as well as it did before. So we've gotten really good with our disease-modifying therapies at trying to limit the demyelination, the scars that from occurring in the first place. And where most of the research is going is on that repair thing. How can we actually enhance that repair in order to try and improve things? We're not very good at that so far clinically. Now, this is an old descriptor from 2002, and I've kind of added to it over time. And you have seen, you've seen various versions of this from various researchers. So what we have is we have a person who goes on in life, and then they have their first attack of clinical inflammation, and we call that clinically isolated syndrome because we've not yet reached the multiple yet, right? We've had a single event. And then they go on in life and they might have what we call relapses or attacks that can be separated anywhere from months to years to even decades sometimes. And they have a second relapse and so on. Over time, they tend to lose their relapses and they kind of grow out of them. And then they move into what we call secondary progressive MS, where they have a slow, gradual worsening over time. The progression is showing you that it is blue here, and so it can actually start quite early on, and early on seems to be inflammation related to incomplete recovery from relapses. And then some people think that once you overcome a certain amount of reserve and it's no longer compensating, that's when you worsen over time. The red is the volume of the brain that tends to decrease over time, and the yellow is the MRI. So you can see that the MRI activity or inflammation is usually about 5 to 10 times greater than what you experience in terms of clinical relapses. And so we use this more and more for monitoring the disease over time, because what we see in terms of the person, the clinical picture, is really just the tip of the iceberg, right? We know that there's a lot of ongoing inflammation in the brain that we are not really seeing clinically. Now, one thing I want to comment on here is this idea of this MS prodrome, which has really come up in recent years, and I'll speak on that further in a later slide, as well as this idea of radiologic isolated syndrome. And that's when people have MRIs for various other reasons, and then they happen to have an MRI that looks exactly like MS, but hasn't had any clinical features so far. So we know that these people probably have that inflammation going on before they have their first clinical manifestation. What we're trying to do in terms of our treatments is trying to prevent the secondary progression from happening. So if you want to break down the multiple sclerosis symptoms, you have the relapse, which, as I talked about, was a clinical event of inflammation. And that's where symptoms come on over days to weeks to months, reach a plateau, and then typically get better, either right back to normal or not quite back to normal. And that's the clinical repair process that goes on. Then we have more chronic and progressive symptoms that are more of a slow, gradual change over time. And people will come in and they'll say, you know what, I just can't walk as well as I could a year before. Like I used to be able to walk 6 blocks and now I can only walk 3. And then that tells us, before my leg starts to drag and I need to sit down, and then that tells us that there has been some progression of their disease. And that's really insidious. Like they just don't notice that on a daily basis. It's more when they think of it in big spans of time. The symptoms are what are outlined here on the top right-hand corner of the slide. So this can be anywhere from numbness and tingling, but it follows particular patterns usually with that numbness and tingling. So they'll say, oh, I had a tingling in my feet, and over the next few days it kind of spread up my leg, and then it spread up into my, well, they don't say trunk, up my abdomen to my belly, or to my belly button, and then down into the other side. And then my legs started to drag a little bit. So those are common symptoms that they have. And down here at the bottom, I've acknowledged that there are paroxysmal symptoms that are quite short, that last for seconds to minutes in MS that we don't normally talk about because it confuses the picture sometimes. But the most typical of that would be like trigeminal neuralgia, where they have lancinating pains. That can be also chronic progressive or relapse related, in that if you have trigeminal neuralgia, you'll get, as a relapse, you'll have repeated shocks of pain that will occur several times an hour for a few days. So you can have that as well. So these are the various types of symptoms that MS can present with, anywhere from vertigo, a spinning sensation, trouble swallowing. A lot of these things tend to go together rather than be isolated. And they don't come in complaining of, unstable vision. They will come in and tell you that they're having difficulty focusing, and that things will look double for a little bit and then zero in. They say they have trouble reaching for things or picking it up or dragging one leg or tripping on it. And your job as a clinician is to try and figure out what those symptoms are. I circled these things of fatigue, depression, anxiety, cognitive issues, and sleep, because those are really common symptoms of MS, but you actually can't make a diagnosis of MS based on those symptoms alone. You need to have the other things of what we call focal neurologic complaints in order to make a diagnosis of MS. And that's because a lot of people live life with depression, anxiety, fatigue, and may not have MS in the end. The problem is that when they type that into the Google machine, the first thing that comes back is MS. So they think that they have MS. So a lot of what we do as MS clinicians is actually rule out MS for people. And we use these red flags to try and diagnose MS. So when we look at them, if they're younger, we tend to think, oh yeah, that's a higher chance that they might have MS, rather than if they're in their 60s or 70s. Usually their symptoms are really definite. So they can tell you exactly when they started, how they progressed over time, and they really affect, the symptoms really affect their lives. So if someone has kind of like tingling and it kind of goes away when they change position, or it kind of is the same for months on end, that does not fit with MS. We really do use that definitive worsening, plateau, and getting better. It often worsens with exertion and heat. We try and focus it down. There's some more common areas that we try and localize our symptoms to. And we try and ask a history about whether they're having trouble with weakness on one side, tingling, double vision, things like that. Now, in terms of clinical subtypes of MS, I saw that we had shared this with you last week, and the most common type is the relapsing remitting MS type, which I described a little bit earlier on that graph. And over time, the majority of those patients will move into what we call secondary progressive MS. There is a proportion of MS patients called primary progressive where they never actually have any relapses at the beginning. They just have a slow, gradual worsening over time. And usually those are more men, usually over the age of 50. And then there is the occasional person, and I put this in here after I saw what we did last week, that has a single attack of MS and maybe has nothing else over time. Or there's also single attack progressive MS, where they have a single attack maybe in their 20s and then they're fine for decades. And then in their 50s, they notice a slow, gradual worsening and have moved right into progressive MS. So most of the treatments that have been developed to this point are for that relapsing remitting group of patients. And why is that? So we're going to go through that after we go through a little bit about how we diagnose MS. So I actually have touched upon that already, talking about how we look for the red flags, the young, the prototypical time course of a relapse, things like that. It's important to remember as researchers that MS is a clinical diagnosis. So it's really, really based on this history and then this physical exam. We look at whether there's history of clinical relapses, and then we try and find focal neurologic changes on exam. There are new clinical criteria that have been put out in 2017, which allow us to make a diagnosis based on lesions that are in particular areas of the brain. And as well, we can use our cerebral spinal fluid to look for oligoclonal banding, which can now give us an idea about dissemination in time. And this is just showing you some of the prototypical lesions that we'll see in MS. This is an old MRI from a 16-year-old that I treated a number of years ago. So just going back to that idea of these pre-MS states, because if we're really going to try and cure MS, I think, for you young researchers out there, we're going to want to try and figure out what are these pre-MS states, and then how do we actually change disease ultimately by treating people maybe with lifestyle strategies and things in these pre-MS states. So it has been shown that there is an MS prodrome, and these are people that have kind of vague symptoms like what I was talking about, the fatigue, the numbness and tingling, that kind of thing, and they go to their physician a lot for up to 5 years prior to their diagnosis, and they have increased prescription drug use, which are often antidepressants, anti-anxiolytics, as well as neuropathic pain medications. Radiologic isolated syndrome is actually a kind of a different scenario where there's no history of relapses, but the MRI looks like MS. And we follow those people closely because about 10% of them will convert to MS with clinical manifestations per year over 36 months. Interestingly, though, there is a proportion of those radiologic isolated syndrome patients that are followed for over 20 years that never actually manifest signs of MS. And what is it about them? Do they have an asymptomatic MS? You know, we need to figure that out more. There's clinically isolated syndrome, which is the first clinical spell of demyelination. And if they have an abnormal MRI, meaning lesions that look consistent with multiple sclerosis, then they will have a high chance of having a second event in the next 20 years. But if they have a normal MRI, they have a much lesser chance. So you can have demyelination with a normal brain MRI and then never develop MS in the future. And so what is that? What is different about those people? And that is where I like to have help from researchers like you guys to try and figure that out. Now, I threw this slide in. I normally give this slide to GPs, but I wanted to let you know that actually we see a lot of patients in the MS clinic that don't actually end up having MS. And they, over various studies, this is just one of them, when they looked at a consecutive series of patients that were referred to evaluate the possibility of MS, either from family doctors or neurologists, to MS specialists, only 33% were actually diagnosed as having MS. Now, if the people were referred because of clinical symptoms that they were having, then it was about half. But we have a lot of people that are referred to the clinic because they have white spots on their MRI and someone calls that MS. And in the end, only 11% of those patients end up having MS in that case series. So why are there white spots on the MRI? Well, as you know, you can get white spots just with normal aging, with hypertension, smoking, migraine. And so we spend a lot of our time actually ruling out MS for people. Now, so then what we think about is when we want to look at mimics of MS, other diseases that can look a lot like it, we zone in on whether there were atypical features in their history, on whether their exam is too normal, for instance, on whether their MRI looks more like non-specific white matter lesions of aging versus actual MS-like lesions, and when their spinal fluid is normal. So these are the things that help us think about other things. So let's talk a little bit more about what the clinical course of MS can be. My take-home message for this section is that MS is variable, and the experience of MS is unique for every single person. So this actually requires a very personalized approach for that person, and you can't actually assume how MS is going to affect a person because it is so unique, and every MS patient will tell you this. Now, Loveland brought up a new type of way of looking at clinical courses of what we call CIS, or relapsing remitting MS. And this actually looks at how we monitor people over time. So people can be diagnosed with that clinically isolated syndrome, that first attack of MS. And then they can remain that way for years and years. And we follow them. They don't have changes on MRI. And then when they're stable, we call them not active. But then as soon as they're active, meaning that they have new lesions on MRI or new clinical relapses, then we reclassify them as relapsing remitting MS. And I should put a little other arrow in there saying that if we do CSF on them and they have oligoclonal banding, sometimes we can move them right to relapsing remitting MS. Now, when we have relapsing remitting patients and we follow them over time, and say they're either on therapy or not on disease-modifying therapies, they can be what we call not active, so completely stable and not having changes on their MRI over time, which we may do every year or 2 years, and we just follow them. But then there are people who are what we call active, and these are people that have clinical relapses or new spots on MRI or GAD-enhancing spots on MRI, which we call subclinical activity of their MS. And the reason why that group is important is that is the group that we are going to want to treat with disease-modifying therapies to the point that they're not active anymore and they're stable. That's our goal. We want people to be stable with their multiple sclerosis. And this has sort of changed the way that we've also looked at progressive MS. So it used to be that people were diagnosed with primary progressive or secondary progressive MS. And then we would kind of say, oh, well, we don't have any treatment options for you. You know, keep well, participate in our clinical trials, don't smoke, that kind of thing. But a lot of people felt like we didn't have a lot to offer them. But now we have ways of classifying these people with progressive MS. So we now recognize that even people that have primary progressive MS can have occasional relapses and can have new inflammation on MRI. It's less common, but it's there. And so they can have what we call active with relapses and GAD-enhancing lesions on MRI, and then they can have the clinical progression on top of that. They may come in and see you and they say, oh, I feel the same as a year ago, so I haven't had any progression. But when you do your follow-up MRI on them, they have a new GAD-enhancing lesion, and so they're what we call active. So there's active inflammation ongoing. Maybe you do MRI on them because you're trying to think about whether you should treat them with disease-modifying therapies, and we have a few options for that now. And when we do the MRI looks the same as it was 2 years ago. So there's what we call no activity. There's no GAD-enhancing lesions, no change on it. But when you talk to them, they say, yeah, I'm definitely worse than I was a year ago. You know, I just can't do things the same. My balance is off. I'm having to use a walker now, and I used a cane before. So those people are what we call not active. The inflammation is not active, but they're having progression, which is the clinical degeneration. And then there are a group of people who are not active and don't progress. And so they're labeled as having primary progressive MS or secondary progressive MS, and they just kind of stay the same. They kind of get to a level of disability, maybe walking with a walker, and then they just stay there for years. And why is that different for each person? And I don't know, but I'd love it if you guys figure that out, as I said. I thought I would throw in here some standard measures of disease. We talked a little bit about that last year, Jody Burton and I, when we talked at the NMS Summer School. So how we monitor patients in clinic is we monitor them clinically through clinical exams, and then we put that in a score of what we call an EDSS, which is primarily motor and then function-based. Then we have MRI, where we monitor for new inflammation and new activity over time. We look at the timed walk, which can give us some ideas as to whether someone has progressed or not, is how fast they're able to walk 25 feet. And then we do a cognitive screening on the SDMT, which is a quick 90-second test, and then gives us an idea over time as to whether they have changed or not. So as I said before, MS is different for each person. And overall, about 15% of people will tend to become severely disabled. You notice these are old references that I'm using. But that's where most of the natural history data has come from, because we have now tried to change natural history a little bit with our disease-modifying therapies. Over about 10 years, about half of people will start to accumulate disability, and about half of people at between 15 and 28 years will use a walking aid. There is this idea of this benign MS, which is about 10% of patients where they just are kind of free of ambulatory disability. I say walking disability there because we now know that a lot of people that we previously labeled as benign MS have cognitive issues that are extremely impactful that we didn't historically recognize. So this can be really disabling to a person in their 20s to 40s. Remember, I told you that's when most people are diagnosed with their MS, and that means that they can't work, that they can't contribute to their family. There are some factors which are associated with worse clinical course at diagnosis, and this was recently published in our Canadian treatment guidelines, I think last week. And these are people that are a little bit older, are male if they're non-white ethnicity, or if they have comorbidities like hypertension, smoking, things like that. If they have a lot of relapses right close to the time after they're diagnosed, and that's associated with a worse clinical course, and if they have more severe relapses that require high-dose steroids that affect their functioning. Now, if they recover well from their relapses, we don't worry as much as if they don't recover well. So say they have a transverse myelitis and inflammation of the spinal cord, and we see them afterward in 3 to 6 months, and they're still walking with a cane. And to me as a clinician, that's a real warning sign that there's going to be a problem with this person, and I probably want to get them on to an effective therapy. And then we use MRI. We look at mainly T2 lesions and GAD-enhancing lesions. Spinal cord lesions are thought to be a worse prognosis, and brain atrophy, but that's difficult for us to evaluate clinically. What is so weird about MS, amongst so many different things, is that when people start to progress, remember I talked about secondary progressive, that most relapsing and remitting patients move into, or even primary progressive, because usually it occurs in people over the age of 50, and that's when they're diagnosed and then they have progression. That no matter what type of MS that you have, you usually get some progression in the 5th decade. And even though women are diagnosed with MS earlier than men, they tend to progress at around the same age. So what is it in that 5th decade that kind of tips them over the edge and then they start progressing? When they also get to this magic number of an EDSS with 3, and that's a moderate disability where they have visible disability when you look at them, maybe some troubles with their walking and things, then they tend to progress at the same rate, no matter what type of MS that they had or how many relapses they had before they got to the EDSS-3. So people take a differential period of time to get to EDSS-3, which is mainly inflammation driven and relapse driven. But then after 3 onward, in terms of disability, a certain level of disability, they tend to progress about the same. Whether or not they also have relapses in that period of time, but the rate of progression can be impacted by comorbidities, vitamin D levels, and smoking. So this really tells us, I think, that if we're going to try and intervene with a clinical course of MS over time for a lifetime, we're going to really want to try and target these people, right? And that's where a clinical course has gone, and that's where we've, I think, been most successful. So now that we've gone through a little bit about how we diagnose in the clinical courses of MS, let's talk about different approaches to treating it. So there's 4 types of approaches that I like to talk about. One is how we actually treat the relapses themselves, and we can use super high-dose steroids to try and shorten the duration of the relapse and improve their recovery to the point that they can get back to functioning, and that just shuts down inflammation altogether so that they can start on that course to repair. In the end, that actually doesn't impact their MS overall. It just gets them back to functioning. So if there's a person who has like numbness and tingling and they're able to continue on with their lives pretty much, we may not treat that with steroids. If they are not able to do their job, say they have double vision and can't focus on the computer, then we'll use the high-dose steroids to try and shut that off so they can get back to work. Then we have long-term therapies, disease-modifying therapies, and these are trying to delay the disease course, so trying to delay accumulation of disability. And people actually don't feel better on a daily basis with these therapies, but it's trying to help them over the long term. Whereas the symptomatic treatments are treatments to try to settle symptoms, and they don't actually affect the disease activity, but they help them cope on a daily basis. Say they have severe lancinating pain that bothers them and is burning all day, and they can't sit down and concentrate. So if we can treat that pain appropriately, then we can actually get them back to life, and same with depression, anxiety, things like that. And then finally, I've added in recent years this idea of lifestyle and comorbidity treatments that actually can impact disease activity, make people feel better, and settle the symptoms. So kind of an all-encompassing. We talked about relapse already, so I don't need to go into that in any sort of detail. So what happens when a person we think is having a clinical inflammation event, a relapse? The first thing we do is screen for infection, because their MS can react to the infection and look exactly like a relapse, and we call that a pseudo-relapse, because then our job as clinicians is to treat the infection rather than the inflammation. Then we let our neurologists know, this is when I talk to GPs and things, so that we can maybe look at their therapies and maybe look at switching their disease-modifying therapies. Then we try and stop the inflammation. We do that through rest, IV steroids, or oral steroids. And actually some of the work coming out of Calgary showed that oral steroids were just as effective as IV steroids, and that was through Luan Nets, and just as well tolerated, with Sarah Morrow from London, Ontario. And then we go through counseling, coping strategies. Do they need help with their children? Do they need time off of work? Do they need physio? We go through symptom management if they have symptoms that need to be treated. And then we talk about their disease-modified therapies. Are they on the right therapy, or do we need to consider switching them? So what are these disease-modifying treatments that I keep talking about and I keep referring to? Well, these are therapies that we give to try to stop that EDSS from accumulating over time, to try to stop relapses from happening, to try to stop new MRI inflammation and spots from happening. And we now have brought in this idea of this therapeutic window, that if we treat with these therapies earlier, and as I talked about earlier in the course of disease, within 2 years of diagnosis, that actually is that therapeutic period of time where we maybe can change their trajectory. And we know that if we don't treat them now, for each year that we delay it after their MS onset, that their risk of reaching the EDSS of 4.0 increases. And then, as we know, they will be most likely to progress at that point. There was this very exciting article that was released in JAMA in 2019 that showed that the more aggressive therapies, which are later, mostly have come after 2011 with fingolimod, ocrelizumab, alemtuzumab, that when you use those therapies earlier, that those patients had later conversion. And this is very exciting. We haven't really been able to show that before, because remember that most of the aggressive or effective DMTs that we've developed have really occurred after 2011. So how do we show impact on a lifetime course of disease when we've only been using these therapies for a few years? This is just showing you that with all these different therapies, and this is looking at all the different clinical trials that have been happening on all the different agents, that when you treated people earlier and you plot that as per age, that you inhibit that disability worsening. And even though there is some effect of these agents kind of later on, and that's more in different types of MS, more progressive MS and things, that there is less of a chance of affecting the disability worsening over time. So what are the options that we have available? One of the exciting things for me as a clinician, and what I spend a lot of my time about, is what kind of therapies do we have? And I say to people, you know what, let's just try one. If it doesn't work for you, we'll switch in between until we find the right one. And I saw a thing on the internet saying that the average MS patient will be on average 4 to 5 different therapies now throughout the course of their lifetime, which really fits with where I think we're going. We had these injectables that have been around since the 1990s, and they worked a little bit in MS. They prevented about 1 in 3 attacks over time, but people didn't like them. The beta interferons, they felt like they had the flu all the time. The glutathione acetate was pretty well tolerated, but you could get hives with it and little dents in your skin from the injections over the long term. And they weren't as effective at that time. That was what we had. And so we didn't actually take people off of those therapies. We just left them on it for decades because that's all we had. And then in 2006, we started to have monoclonal antibodies with natalizumab coming out, which worked really well. We more recently have alemtuzumab and ocrelizumab, which work really well at affecting MS inflammation and treating our patients. We have a plethora of oral therapies. And some of these are therapies that you take all the time to try and prevent relapses from happening. And some of them are more episodic, or what we call resetting therapies, where you take for a period of time and then it sort of resets the immune system for a while to try and settle disease activity. And those are attractive to people for different kinds of reasons. So we often switch until we find the right match. There's the autologous stem cell transplant, which is still being offered through Calgary, through Jody Burton at your site. And sometimes we will still use cyclophosphamide for those really aggressive therapies to try and break a cycle. And we are getting about 3 new therapies per year. So what are our clinical goals? Well, we have been trying, you might have heard about this idea of NEDA, which is no evidence of disease activity, which is no MRI changes, no relapses, no progression. That idea of that not active, stable patient that I was talking about before in the clinical courses of MS is a goal. More and more, we are also moving towards this idea of minimal evidence of disease activity, because no matter how well a lot of our therapies work, they don't settle all MS activity. And so is a more realistic goal to look at what minimal evidence about disease activity is. The trouble is that we haven't really agreed upon as clinicians what that is for that person, and that's probably very individual dependent, what their disease was like before they started on therapy and then while on therapy. So there's a lot of argument around this right now. Is no evidence of disease activity, is that an appropriate surrogate? And probably in what's come out in the Canadian guidelines is that minimal evidence of disease activity is what we should be striving for. But again, what that is kind of individually based. So this is sort of driving home that message that for these people who are relapsing remitting, or what we call active progressive MS, that we're trying to move them into not active and stable, or MEDA or NEDA, whatever we're trying to have as our goal at the time. And that's our whole kind of treatment goals with our disease-modifying activities. And what's exciting about this is this does get to a group of patients that we traditionally had not really targeted the same before, and it has changed some of our conversations. So I haven't gone into this in a lot of detail, but we have these first-line therapies that we are governed. We are in a public healthcare system, and so we're given a lot of options that we can try as first-line. And these are therapies that are thought to be a little bit safer. I should have put ocrelizumab in there as a, we can use that for what we call highly active patients as possible first-line. And then if people, what we call breakthrough or relapse on the first line therapies, then we can go up to the second line therapies. And then we can switch in between them if they're not controlled on the second line therapies. And then if they break through all of these, then, or some of them, then we can consider autologous stem cell transplant, which we do rarely, but can work really well for the aggressive people. this was my group for the recent treatment guidelines that were published last week, and Jody Burton was on that group with me. It was so much fun, and Dahlia Rotstein out of Toronto. And we have changed the way that we're assessing patients. So remember, I had talked about that when you can make the biggest difference for a person is really in the first 2 to 5 years after their MS diagnosis and onset. And what's been shown now is that if you're going to intervene with these people and escalate their therapies, that you need to consider different criteria in terms of switching. So we have now major criteria, which really are a red flag that you've really got to switch something up and escalate their therapies. And then we have people that have kind of maybe a little bit of a mild relapse on therapy, but they have good recovery. They're still really functional, maybe one new spot on MRI in a year. And we say, oh, you know, that's kind of concerning. Let's just keep a closer eye on you, see how things go for the next year. And we kind of monitor them more closely, but we maybe don't consider switching at that point. So progressive MS, if they're active, we can try the ocrelizumab or more recently the siponimod. But we talk a lot around symptom management, exercise, and that gets into what I'm going to talk about next in terms of comorbid treatment and lifestyle strategies. So my take-home message on disease-modifying therapies is that we have a lot of therapies available that stable relapses and inflammation, better given earlier in the course of the disease and when people are a bit younger. But this is highly based on patient preferences. Do they want to take a pill versus getting an IV infusion every 6 months? What kind of values do they have? Are they planning on getting pregnant? Because some of our patients we can't give certain therapies to if they're wanting to become pregnant. And what kind of complications or side effects are they willing to risk? So for instance, teriflunomide can cause hair loss. I thought, that won't really bother people, but it's amazing how many people that this bothers, and not people that I think would be bothered by hair loss. It's always surprising to me. So a lot of people won't choose teriflunomide because of risks of hair loss. And then cost is a huge part of it because these therapies started around 18 grand per year and go up for from there. And as I talked about, MS patients live a good long time. So how long do we keep them on therapy for? Really for a huge part of their lives. So that's hugely costly to us as a public healthcare system. It's worth it in the end. And there have been various studies showing that there are cost savings in giving people appropriate therapies for their MS, but it's still very costly for us to treat. And I feel like when I talk to patients around what therapy we're going to start with their MS, that really it's like looking at that signpost of where you want to go in the direction, and everything is covered in snow because you don't know how they're going to react to the therapy. You don't know how well it's going to work. And then I say to them, okay, well, let's just try direction, scrape off the snow there, go in that direction. If it doesn't work out, we'll go in another direction. So just finally, in the last couple of minutes here, we have symptomatic treatments and then lifestyle. So just one comment around symptomatic treatments in MS, that the symptoms in MS are variable, often unpredictable on a daily basis. And we have various therapies to try and treat them, but our therapies are not usually MS specific. So if they're having trouble walking, we'll refer them to physiotherapy and occupational therapy, look at walking aids. If they're having depression, we will use antidepressants. If they have numbness and tingling that is painful, we'll treat that with pain medication. We'll treat their spasticity, but that would be the same as a stroke patient who's also having spasticity, and we would use the same components of treatment. And each time we talk about these symptomatic treatments, we talk about lifestyle strategies. So if they're having stiffness or spasticity of their muscles, we'll talk about stretching, yoga, and then we'll talk about medical therapies such as baclofen. And really exciting and empowering to people with MS is this idea of knowing that there are lifestyle factors affecting the MS disease course. Remember, I had talked at the beginning about all those environmental risk factors. So this actually comes full circle back into how we can actually change the course of their MS, possibly just by changing things that they do on a daily basis. So we can treat their comorbidities. This is how we can bring their family doctors in and use the psychologists and the psychiatrists. We can tell them to stop smoking because that will affect their progression from their MS and maybe their rate towards even dying from their MS. The diet is more of a question right now. The obesity has been shown in children to maybe be a risk factor for developing MS later. In adults, it's more uncertain right now. But this whole gut microbiome, I think that there's a lot more that we need to hear about. And a lot of my patients swear by certain diets. And who am I to say that that is not working for them if they feel better on it? So I tell them to try it, see how they feel if they want, that there's no golden rule around diet. But if they feel crappy on it, then get off. We are recognizing more and more that sleep and melatonin release can be helpful with MS, vitamin D recommendations from the MS Society, and then various types of exercise. So there is an exercise thing here from the MS Society making recommendations, which I feel is actually not tailored enough to people that are having more severe disabilities. But there have been various small studies looking at things like using the Wii Fit for a 10-week course, showing that it helped with balance. Even video games, and my young male patients love that idea, and then exercise. And then finally, comorbidities. So comorbidities are common in MS. This is from Ruth Ann Marie, who's really world-renowned for her work in comorbidities in MS in Winnipeg, and showing that we can actually impact our course for our MS patients if we address these things properly. So finally, just to conclude, I hope I have talked to you and you realize that MS is common, that it presents with a variety of MS symptoms, that it's a clinical diagnosis, and we support that by MRI and CSF, that we have different clinical courses of MS, but we're looking more and more around whether there's activity or not, or clinical manifestations of inflammation versus MRI. And that there's different categories of approaches to treating MS. So we actually have a lot that we can offer people with MS over time. And that's it. So any questions? All right.
Hi, Penny. Can you see questions?
Yeah, I can see the question. So there's a question there about whether the lower incidence in South America is actually lower incidence or a function of different diagnostics. That's a really, really good question, and that was addressed kind of, Giovannoni has done some work with that with brain health. And there's some nice papers, I think, from 2016 looking at that. My understanding is that it actually is thought to be a lower incidence, although in developing countries, we now recognize as well that they have less access to MRI and things, and that they're trying to improve the MRI access for that. Do you know that, that answer to that question?
Yeah, I think most of the studies would suggest that it's not due to different diagnostics, the technology, and also the quality of the neurologists, many of which are trained in North America and Europe, are really quite there. Some of the South American studies that I'm aware of have included not only distances away from the equator, but also the idea of the hygiene hypothesis, and that is that in many of these areas, kids are exposed to all sorts of infections, unlike those in first world countries where there's also more frequent use of antibiotics, that the immune system is not educated from a young age, and therefore respond inappropriately when one sees cross-reactive antigen that sets off autoreactive immune cells within an individual.
Yeah, we're too sterile here. And I wonder how COVID is going to change that even more. I've been thinking about that, whether we're going to get even more sterile here, So any comment on why PPMS is predominant in males? So that's a really good question. We don't really know. We know that men in general tend to get MS later than women anyways, and so they get it kind of closer to that progressive time course. And so some people think that maybe they did have initial relapsing events, but that was asymptomatic and they just didn't notice much decades earlier, kind of like that single attack progressive that I kind of referred to. So that's one theory about it. That they just had asymptomatic MS and then they manifest clinically when they no longer have reserve and they're progressing. But we don't really know for sure why that is. Should patients be sent for further investigations regarding MS in the absence of symptoms? Yeah, so I kind of refer to that a little bit through my radiologic isolated syndrome. And if the white spots look like normal aging and they have vascular risk factors and there's no history of MS, then I will just monitor them for a couple of years to make sure that there's no clinical manifestations and there's no changes on MRI, and then let them go. I usually won't investigate them earlier with CSF studies. If they look like they're what we call radiologic isolated syndrome, where the MRI looks typical for MS, but they have no clinical manifestations, then you can do a spinal cord MRI to prognosticate, and you can do CSF to prognosticate. Now, this is actually important to have a discussion with the patient about, because a lot of the work around this has shown that some patients prefer to be investigated regarding prognosis, and then some patients would just prefer to be monitored and be seen on an annual basis, maybe with or without an MRI. And then they have someone to reach out to if they should develop clinical manifestations. And this is very individual. You'd think that all patients would want to have further investigations, but a lot of people don't. They just say, oh, you know, I'd rather forget about MS, try and optimize my lifestyle and live healthy, and then just come see you in a year. So it's very individual dependent. And there are any clinical tests for early indication of MS that could allow for earlier intervention? Yeah, there's a lot of enthusiasm for this. And we don't have any clinical tests that really can help with this. We have some things that we can use maybe potentially in terms of blood biomarkers, in terms of inflammation in MS, where there's a lot of work going on around neurofilaments, things like that. But we don't have this yet right now. It's not reliable enough. And so that's my shout out to you guys. Come up with that stuff, and so we could do it, because wouldn't it be nice to do a blood test? That'd be so great. Why is it that males have a more severe course progression? Does that have to do with hormones like estrogen? So there is some thoughts around this with women, where, for instance, in pediatric MS, the incidence of MS is 1 female to 1 male before puberty, and then after puberty it switches to 3 women for every 1 male. So there is a definite puberty association. There's a definite estrogen association. We know that pregnancy has less MS activity, and then that increases postpartum for the first 3 months. So we know that the female hormones and their interactions with the immune system do alter the disease for women. And there have been trials looking at different types, but I understand there's like 25 different types of estradiol. And so they haven't really shown that giving women extra supplementation really helps, or taking hormone replacement therapy or birth control pill really affects the disease activity overall. So that's an indirect way of how it is for women, and getting back to men on why they have a more severe disease course. And my thinking is that probably does have something to do with the estrogen, maybe the slightly protective effect of having multiple children, that over time and things like that. But I think there's still a lot more that we need to know about that in order to look at why it is different for men. And you know what? You can't really give men estrogen. They don't really like taking it and developing breasts and things like that. So we still have to work that out a bit more, but those are really good thoughts. Is there any evidence to link chronic fatigue syndrome to the MS or the MS prodrome? I think there might be a link there to the MS prodrome, and that's why I brought it up to the group today. I don't normally go into that depth on my clinical talks, but I thought this is a really exciting area for researchers, is to look at that idea of an MS prodrome, who is it who are high risk with chronic fatigue or depression, anxiety, who might develop MS in the future, and how do we separate out those people and then try and connect them early so that we can maybe prevent the later manifestations. Yeah, that's it.
Well, Penny, thanks very, very much. Great job. And this talk is attended not only by summer students who are new to MS, but also by, I see some senior faculty there. I see a number of postdocs who are actually already quite well versed in other aspects of MS, but all needing this grounding of clinical MS. And I think you did a great job there. So thank you very, very much.
So for me, did you understand the idea between active, progressive, in the clinical manifestations? Because sometimes I have trouble explaining that to med students, so I tried to approach it in a different way today. Did that make sense?
It made sense to me.
Good.
For sure.
Okay. Oh yes, you guys can have a copy of the PowerPoint. I sent it to Neetu yesterday. So Neetu, feel free to share that with people. This is an open kind of thing. And yeah, happy to have questions afterwards. Just email me.
Thank you very much, everybody.
Okay.
And thanks to you for arranging. Thank you all.
Thank you. Bye.